We're really excited to have you here. Whenever we talk about scars, it's always a really popular topic because we all have them, or we're about to have them, or we're trying to avoid them or improve them. So it's really kind of a popular topic. I see we're up to 26 now, so I think we'll get started. So officially, welcome to tonight's session on scars and thyroid cancer surgery. Today's session is being co-hosted by the American Head and Neck Society and ThyCa. I'll just do a quick overview of our format and the agenda. We'll do a couple of introductions, and then we'll dive right in. So we'll pose some questions that we've already come up with and that some of you have submitted, and the panelists will tackle those. And while they are answering those questions, all of you in the audience can feel free to ask additional questions by way of the question and answer box. We will monitor those. Try and keep them general. You don't have to provide a lot of personal information. And if similar type questions come in, we might combine them and pose that to our panelists. And we'll do our best to get as many of these questions submitted to them. And please stay on topic. The topic today is scars. So try and stay on that topic. And just a heads up that this session is being recorded, and in short order after this, we will do a little bit of editing to get rid of some of the technical stuff at the beginning, and we'll put it out on YouTube for anybody that missed the session or anybody that's here today that would like to maybe rewatch portions of it. So our panelists, I'm going to introduce myself. I'm one of the moderators, Daria Gerald. I'm with ThyCa, and I'm really happy to be here. And I'll introduce Dr. Ho. Please introduce yourself, doctor, and then maybe toss it over to the panelists for us.
Great. Thanks, Daria. Daria and I have been working on this for some time now. This is our second one. It's been such a pleasure to work with her and to continue our relationship with ThyCa, because I feel like this is really where the rubber hits the road, where we can really get a lot of direct answers in ways that you can't really get from a website or other formats. So I'm Alan Hill. I'm a professor of surgery at Cedars-Sinai Medical Center in Los Angeles. I focus on thyroid and parathyroid surgery. I'm delighted to introduce, or at least help moderate the panel along with Daria. Hopefully we'll get some good dialogue today. So Michael, why don't you move on and discuss, introduce yourself, and we'll go from there.
How's it going? I'm Mike Orestes. I'm at Walter Reed. I'm at Walter Reed right now, and I do predominantly endocrine surgery as well, along with some head and neck cancer and some laryngeal surgery. I'm happy to be here. I've been on some of the Twitter chats before, and happy to be here.
Great, thanks. And Andrew?
Yeah, hi, Andrew Roscoe, one of the head and neck surgeons at University of Michigan. Really excited to be a part of the panel and can't wait to talk more about this. Thanks so much for the invite.
Thanks so much. Mary, if you're able to hear us, go ahead and give yourself an introduction if you could. Thank you. Oh, there you are. Wonderful.
Yep, here I am. Hey, I'm so sorry. I'm actually leaving another meeting and going right back to my computer, so I apologize. I'm Mary Seeblick. I'm an endocrine head and neck surgeon at Emory University, and I do a little bit of other head and neck surgery, but I'm probably 75% thyroid and parathyroid. And this is such a fascinating topic to me. And I'm so excited to be part of this and to learn with the patients and to talk about what I've learned. It's a very important topic. And thank you.
Great. And then finally, we have a special guest from the facial plastic and reconstructive surgery world, Hutan Zandafar. And we're so delighted to have him on board for, again, this very more unique topic. So Hutan, if you could tell us a little bit about yourself.
Thank you, Alan. So I'm Hutan Zandafar, as Dr. Ho said. I'm a facial plastic and reconstructive surgeon in Los Angeles on staff at Cedars, and I'm happy to be here. Thank you for having me, the outsider.
Awesome. Well, we already have questions submitted, which is absolutely amazing. There's 3 questions already, but why don't we get started with our first question? And that is, I haven't yet scheduled my thyroidectomy. So maybe there's people out there on this call that have not yet had any surgery. How do I know if I'm a candidate for some of the scarless surgeries that I've been hearing about?
Great. Yeah. So Derry, this is definitely a hot topic. One where there's a lot of noise, dialogue, both online and offline, and something that the surgeons themselves are still kind of getting a grasp on for who has indicated the pros and the cons. We'd love to start with maybe Andrew Roscoe from Michigan, who actually is doing some of the transoral work for doing the scarless remote access procedures. And maybe Andrew, you could tell us a little bit about the indications and the contraindications, and B, what goes into this and how it's different from conventional surgery.
Yeah, sure. I mean, it's a great question and really a hot topic. I mean, the scarless approach that we talk about is we call it the transvestibular approach, which is rather than making the traditional incision in the neck, there's a laparoscopic approach where there's 3 small incisions that are placed just behind the lip. So it's inside the mouth, just behind the lip. And then we use laparoscopic instruments to remotely access the thyroid that way. It's really, I think, a great approach and a great advance in the right patient. It does avoid the scar. Some people even talk about the fact that there's a slight tightening of the neck skin, so you almost get a little bit of a neck lift through that procedure. But that's a bonus points. That's not really the indication for that, obviously. In terms of the right patient for that, I mean, really those are best done because you're trying to take out the thyroid through a very small incision behind the lip. This needs to be a small thyroid. So it has to be either a lobe or a nodule that's, 4 centimeters. Some people are pushing the envelope with a little bit bigger, but a 4 centimeter or less nodule really is kind of ideal. This wouldn't be the right, in my opinion, this wouldn't be the right approach for somebody who has a more advanced thyroid cancer, for example, with significant bulky nodal disease. So if you're just doing taking out a lobe or even a total thyroid for a nodule, a small cancer, even a Graves or a Graves patient or a toxic nodule or some sort of hyperthyroidism, that's a great patient for that. We also do this approach for hyperparathyroidism, so a patient who has a parathyroid adenoma, where it's a localized adenoma that we can see on imaging. So that's an adenoma. It's just a parathyroid gland that's overactive. If we can see that on imaging and can focus our surgery on that, then that's another great approach for that. I think, again, I think there's pluses, there's minuses on that. One kind of extra risk that we see with the transvestibular approach is there's a nerve that does give sensation to the lip that is at risk for stretch injury with that approach, and that's unique, obviously, to the transvestibular approach. You don't have that with a traditional transcervical or through the neck skin approach. The kind of other unique things, when you've looked at the big theories about complication rates, the complications really are quite similar in terms of the risk to injuries to the nerves to the vocal cords or bleeding or infection, et cetera. So it has been shown to be a safe procedure in the right hands, and it does have to be the right patient, like you said.
Excellent. What I would say is it's one of those emerging technologies and innovations that not every thyroid surgeon has yet come on board with or without. Do you feel like this is something that patients should be on the lookout? Like, is there room to run on this? Is this going to be a niche type of technique?
I think there's adopters and believers, and then there's the skeptics, as with any new technology, and I fall much more on the adopters and believer side for this particular approach. I think this is very similar to inguinal herniary surgery, where historically that was a very straightforward operation through an incision, and now when people are doing inguinal hernia surgeries, as an example, it's almost always done laparoscopically. And I think that, again, with my crystal ball, that I think we'll see more and more of this in the right patient, just because if you can avoid a scar, then why not avoid a scar if it's going to be just as safe as any other procedure? There are times when that's not the right surgery. And again, I think having a thoughtful surgeon and a good conversation makes a big difference there.
Are there any patients that you've encountered that really wanted this surgery, just because we have a lot of patients in the audience, that where you flat out felt like it was the wrong operation? Could you give us some examples?
Absolutely. So any patient where you're worried about to me, if I have to do a dissection of nerve because I'm worried about a cancer that is having extrathyroidal extension, especially posteriorly on the gland towards the nerve side, I don't think that's the right approach. Any patient with bulky nodal disease or really significant nodal disease in the central neck, obviously the lateral neck is a completely different beast, but that
Okay.
I'd be apprehensive about. Any large, a lot of patients have talked about it and they just have glands that are too large to remove that way. I give the example, if you've ever tried to move your house and you've tried to move a couch through a doorway that's too small, it's not a fun experience. It's the same thing when you're trying to do that through a small, minimally invasive procedure.
That's a good analogy. Mary or Michael, could I ask if you've had any experience or any insights on some of the other remote access or scarless surgeries, such as transaxillary, like through the armpit, or through robotic surgery in those senses? At your institutions, have you guys had any experience?
So I can answer that a little bit from a historical standpoint. I was very intrigued when the FDA first gave device approval for transaxillary robotic approach to the neck. But then as I was getting ready to go train, the FDA pulled device approval about 18 months later because of some unexpected complications. So it is important for the person who is seeking to find out if they're a good candidate for a transaxillary robotic approach is it's not minimally invasive. It's actually a longer incision in the near the armpit or axilla. And so it actually is a longer path to the thyroid gland. It's a fascinating technology and it could be correct for the right patient, but it is actually not minimally invasive. It is more invasive and more a longer surgical path to get to the thyroid. So I did not adopt it into my practice for those reasons, but it's a fascinating technology. And many others have tried to use the robot or do use the robot through other approaches, which again is not minimally invasive, but it's a method for avoiding a visible scar in the neck in the front.
Michael, I think she might be referring to one of the other remote access techniques, such as facelift approach, which again is sort of a longer incision. Do you know anything about that approach in terms of recommendations or any other scarless approach that you might favor?
Yeah, I think really that a lot of the approaches like the transaxillary and the facelift approach, or some of the what they call dorsal approaches to the thyroid, I've never done any of them. I really think that, you know, if you're going to do a remote access approach, I think the transvestibular approach is probably the way to go. You know, I often tell patients I haven't adopted the transvestibular approach yet in my practice either, but I do think the scars, you know, people tend to be pretty happy with their scar, especially if you wait long enough, 6 months to a year, and most patients aren't as bothered by their scar. So, well, I think there's probably a role for it in select patients. I don't think the small scar that we often leave with traditional thyroid surgery is really disfiguring in many patients.
Oh, great. That brings us to, I guess, our next question, Daria. If you want to move on to question 2, it seems like we've done a good job of covering that first topic.
Yeah, and before we jump into question 2, I just want to tell our audience that I do see all the questions that are in here. There's 7 of them already, and some of it is going to get addressed, I think, with some of the coming questions. And if not, then I'll definitely come back and make sure that we get these more specific items asked. So hang in there, everybody. Our next question, I'm scheduled for surgery soon. What can the surgeon do to minimize my scar?
So this sounds like almost like a before incision type of question. Is that right?
Right. Like maybe questions to ask the surgeon as you're sitting down with him or with her right before your surgery.
Yeah, maybe Mary, we'll start with you, because I wonder if maybe it has to do with the size of the incision, the location, et cetera. What would you make of that, since you have a lot of experience?
So there's an old saying among thyroid surgeons that the timid surgeon makes a long incision, the bold surgeon makes a short incision, and the good surgeon makes an adequate incision. And so that's the discussion I have with my patients, that the incision is really customized to the size of their thyroid gland. And you want the incision to be long enough, but not too long. And so that's a very important discussion to have. If the incision is too short for the size of the thyroid, then the skin may get damaged as it's being stretched around to try to get the thyroid out. And I think another important question to ask of your surgeon is, how is it repaired and closed at the end of surgery? Because there are very, very good techniques for closure that are borrowed from the cosmetic surgeons. And many of us do use a technique that completely buries the stitches in the closure, and the only thing that may be on the surface is glue or waterproof covering. So I think those are two really important things to discuss with your surgeon: length that's customized to your thyroid, and how your skin will be closed. And those are two, I think, proactive things that can make it look really nice once it's healed.
You mentioned two things that I think Dr. Zandifar will be very interested to comment on. Before we get to him, though, because I feel like he will have a lot to say. Michael or Andrew, any other proactive or preoperative things you do to help patients maximize or minimize the appearance of their scar?
My bias still is, in terms of location too, is to find a nice skin crease that is over the thyroid, so that, again, minimize stretching, et cetera. But I think that an appropriate incision in a skin crease is always going to heal better than even a slightly smaller incision outside of a skin crease. So that's just a very simple thing that I think most of us are thinking about.
Okay.
Yeah, I like to, a couple things. I sometimes like to mark the incisions when the patient's upright before going to the OR, and that avoids dragging the scar down when you're asleep. When they wake up, dragging it down over the sternum, which doesn't really look very good. The other things, I would echo the sentiment about making the right size incision for sure, because a very small incision trying to struggle to get a thyroid out, you may not achieve some of the goals of thyroid surgery, like preserving the nerve and taking out the thyroid in one piece. And certainly surgeons that make too small of an incision or resist the urge to make a larger incision when they need it, that should be avoided, because really the scar is important, but getting your thyroid out and getting your cancer cured or wherever you're taking it out for is just as important, if not more important, than their scar. So I think those are really important. I do also talk to my patients, especially patients with darker skin, about their history of keloid formation or hypertrophic scars. And I think we'll address that as well later. And sometimes I'll do some prophylactic measures such as injection of steroid, use of non-absorbable subcuticular stitches sometimes seems to help with prevention of those keloids.
That's perfect. Yeah, I would echo just very quickly, it's easy for surgeons to sometimes want to pander to a patient's wishes, small incision, make it really low, et cetera, et cetera. But you're right. Everyone's saying the same thing. We want to make sure that the scar can be very beautiful and taken care of, even if it is a little larger than you might expect, and especially with the skin crease and other techniques we've learned. So maybe we'll chat with Hutan now about what he thinks about these. I think you've probably seen your fair share of thyroidectomy scars gone sideways. And is there anything based on this question you would like to address about how to, proactively prevent a bad scar?
So let me just reemphasize what everybody says. At the end of the day, you want to get the cancer out as the best as possible. And if the scar should be to some degree secondary, part of it is because we're there to treat cancer. The other part is that there are a lot of things we can do for the scar afterwards that minimizes its appearance and will improve it, even if it's not improved. I'll second almost everything that everyone said. Location of the scar is one of the best ways to hide it. I mean, we were talking about a facelift approach. Why is that an approach? That's definitely not minimally invasive. It's a fairly big scar, but it's hidden in places that no one will ever see. So that gives us the best way of camouflaging the scar. I think that it's important to keep in mind the skin type that we are operating on as well. Certain skin types, the ones that are darker, have more pigment in them, tend to respond poorly to crushing injuries. So those skins should be handled a little bit more diligently than skins that don't have a lot of pigment in them. And the type of sutures that we use, so that was mentioned, I totally agree. The sutures that cause less inflammation during the healing process or less inflammation for a shorter period of time tend to heal better, have less cases of hyperpigmentation. Scars that are darker have less cases of hypertrophy and keloid. So those are all something to take in consideration. I like a chromic suture, which, because it dissolves faster than a Vicryl or PDS, these are just, they stay in longer, they cause a much more prolonged inflammation. I like the buried suture that was mentioned, but I use a Proline suture because, again, it causes very little, if any, inflammation, and inflammation at the end of the day is the enemy of the scar. And so if we can minimize the inflammation, we can get a much better scar.
Just if I could just talk shop with you a little bit, Hutan, it seems a little divergent. I would think chromics are highly pro-inflammatory, just as much as maybe prolines are much more inert and not inflammatory. So is there a reason why you like these extremes? These presumed extremes.
So if a buried clear proline is probably the best for scar appearance, and but it doesn't get dissolved, so it gets spit through the incision from time to time, which people don't like. I like chromic because it dissolves faster. Yes, it is pro-inflammatory, but it dissolves much faster. We've all had Vicryl sutures that spit. We've all had PDS sutures that spit, but I'd say very seldom do we get chromic sutures that spit. They just get dissolved by the body. And when they stay there for a prolonged period of inflammation, that's what's promoting that hypertrophic scar. That's what's promoting that keloid. And at times that's what's promoting that hyperpigmentation of the scar. So really, if we can decrease the duration of inflammation and if we can minimize the amount of it, it's best. But yeah, I mean, I've closed facelift incisions with buried clear prolines to get the minimized scarring. So yeah, that's ideal, but the spitting, the suture coming out of the wound year later sometimes causes a little bit of concern for patients. I find that chromic is absolutely adequate.
Okay. And last question, Hutan, is there anything that you do in particular after the surgery is done that the patient can do proactively as soon as the sutures are out and the surgeon gives the patient a go ahead? Any ointments, any creams, any techniques, any avoidance of the sun, that kind of thing that you would recommend as a normal course in order to maximize the cosmesis?
So, the sutures generally come out a week later. If we can continue to put tape dressing over it to decrease the tension on the wound for maybe another week or two, that really helps to decrease the risk of hypertrophic scar. What I really like is silicone. And it comes in various shapes. There's silicone gels, there's silicone sheets, and silicone sheets are great. You put it on, it stays on. You could put it on for 6 hours a day. You put it on at nighttime, you go to sleep, and then you take it off during the day and go on. I've certainly had patients that leave it on for a long time. There's really, as long as you're not getting any kind of a rash with this or any kind of a skin irritation, that's totally fine as well. It hydrates the wound. It allows the redness to go away faster. It decreases the likelihood of a hypertrophic scar or keloid by allowing the wound to flatten. So I do like silicone a lot for that. Sunscreen is a must, truthfully, especially within the first 6 months. Scars pigment differently. And if you allow them to, then it will be permanent. So if you're out in the sun, put on sunscreen, reapply every 2 hours while you're in the sun. If you're in water, reapply as soon as you get out of water. These are good general sunscreen rules anyways, but if you're trying to avoid scarring, that's something that you can do. So those are the just topical stuff that I like. I know there's a lot of other creams out there, and they're varying degrees of success with them. People talk about vitamin E creams and so on. I just haven't seen too many data to say that that works really well.
If I could jump in, we're kind of teetering on some of the questions that have popped in. And you mentioned the silicone. Somebody's asking about silicone tape and if it's okay to wear it continuously for days without changing it. I guess it's so sticky that they don't like peeling it off.
You know, as I wouldn't go days, but if you're putting it on for like a day or day and a half, that's okay. Anything you put on the skin for a long time tends to plug up pores and just kind of affect it in that way. So it's not dangerous to do, but it's not necessarily advisable. I would take it off and then reapply it. Ideally, every night, just put it on and then take it off. But if you're wearing it for one day, it's okay.
And when do you start using the silicone? Is it like as soon as the sutures come out, or is it when?
You start using it as soon as the sutures come out, as soon as the tape dressing is off. You can just put the silicone right on top.
Can we
And
ask if the rest? Oh, go ahead, Derek. Go ahead.
well, you mentioned sunscreen, and somebody's asking, is a mineral-based sunscreen better than like a chemical or a normal-based sunscreen on the scars? What's the best sunscreen?
So in general, the best sunscreens are the ones that are mineral-based to begin with. They're the ones that have zinc oxide, titanium oxide, and other types of metal oxides. They're not chemical-based. And so what does that mean? These are made of very fine micronized reflective material. So what happens is you put it on the skin and they just reflect the rays of sun away from the skin. The chemical ones get absorbed. What happens with that is that the sun comes in, gets absorbed by these chemicals, and the free radicals are neutralized through the chemical-based ones. So the ones that have zinc oxide, the mineral ones are just better sunscreens, more effective at what they do. They stick on a little bit more. These are the old school, back in the days, they weren't micronized. They were the bullfrog sunscreens people used to wear on their noses and on their lips, you know, and they were very effective for that very reason, that they just reflect the sunlight as opposed to absorbing it and neutralizing it.
And somebody's asking about a specific item. I don't even know if I'm going to pronounce it right. Biocornium. Is
Biocornium? Yes. Okay, that's perfect. I like biocornium. Biocornium has a combination of silicone as well as sunscreen. And I like it for the fact that it's just 2-in-1. I don't necessarily like it any more or less than you putting a silicone sheet or putting silicone on and putting sunscreen on. So it's just effective in that. The one thing I'll say is that biocornium does have chemical sunscreens and it doesn't have the mineral sunscreens.
Okay, so I think we answered a bunch of stuff that was submitted. So that's awesome.
Can I just ask if any of the other surgeons have other routine recommendations for their post-surgical patients? Maybe Mary, I'll start with you.
Thank you. I was going to comment that every surgeon has their own little tricks and biases. I do have a trick for people who are prone to hypertrophic or keloid scars, and there's a particular tape that keeps the tension off the incision called Prineo that I will use for somebody with prone to that, because one of the factors that can also cause a keloid is stretching across the incision. So that Prineo tape or glue takes about 7 to 10 days to kind of peel off on its own. And at that point is where I recommend to my patients, if they're willing and if they're able to without discomfort, is to start massaging their incision. And the massage may be just really important to bring extra blood supply to the skin edges. But there have been some studies that slightly support vitamin E, aloe, and onion extract, which is the foundation of a brand name scar cream called Mederma. I don't endorse any one. I don't get paid by Mederma at all, but those compounds have been shown to have some effect on improving scars faster. It's also important to reassure my patients that even without active scar management or incision management, in about 3 months, the color of the scar will fade to the surrounding skin color or start to. And so certainly there are patients who are reluctant to touch their scar. If they just wait long enough, the incision starts to look really good anyway. But aloe, vitamin E, and Mederma all have some properties that can improve and flatten a scar. I like the silicone layer that you can put on your incision to flatten it a little faster. And we have a brochure that explains all this, but I have a funny thing I did. I went into Chat GPT just to, that's that artificial intelligence. And I typed in, what can you do to make a thyroidectomy incision look the best? And it spit out in like 5 seconds, it spit out exactly what our brochure said. So I was kind of happy about that. But this is a really important thing to have a dialogue with your surgeon about. And there are many things that can be done to improve the skin health and the incision health. And I want to reiterate sunscreen. I actually recommend more of a scarf than putting anything chemical or zinc oxide. But it depends on your climate and what you're planning to do. So those are all great tips.
So one person is asking about applying things and touching the scar. Should they use their hands or like a roller? What's the best way to do that?
Andrew, would you mind maybe taking that one?
Yeah, sure. I mean, I think it's whatever you're comfortable with, to be really honest. There's no harm once your incision has healed. And that's really over the course of a week, and that skin is actually sealed up to touch your incision. If you're more comfortable with a roller or something else, I think that's perfectly fine as well. To highlight that point that Mary had just said on the vitamin E, I really do stress vitamin E and massage. I think it does a couple of things, something obviously with the scar itself, but I think also for the skin, a lot with the underlying layers. So we've seen those scars that all tether down or stick down to the muscles underneath. And I think that massaging and getting that skin moving can really help to make sure that that skin doesn't stick to that. And again, I tell my patients, listen to their bodies. Don't be so aggressive that it's uncomfortable, but to actually get that skin really moving. And I think that helps with the lymphedema as well, which is that swelling and the fluid that builds up in the skin. We all have swelling and leaky blood vessels, and that fluid, as it comes to the incision, it's almost like a dam in the river where it just stops and it builds up. And by massaging that, again, my preference is vitamin E, but really with just about anything you want, can help to move that fluid around. So I think
for the patients there, could you just maybe spend 10 seconds and say what your technique is? Is it with a warm compress? Is it circular? For how many times, for how many minutes, how many times a day?
Yeah, that's great. Circular is really my preference, a circular, and I try to tell them to really actually make the skin move. So just like when I'm moving my cheeks, if I massage my skin, the skin will move over the tissues underneath. And I try to get them to have that skin moving. That's usually about 2 to 3 weeks after surgery that I have them doing that. If you did that 2 to 3 days after surgery, I'd be worried about the incision opening up, et cetera, if you're really being aggressive there. So I wait a couple of weeks and then have them do a circular motion with vitamin E as my typical thing.
Okay. And then Michael, let's have you answer this question, which has to do with Q2, which is the magical properties of Dermabond, or purported magical properties. Do you ever use Dermabond? I have patients ask about it. Some facial plastic surgeons swear by it. Do you use it, or do you find that it helps?
I do like Dermabond, and primarily, it's not magic, right? There are other things to close with. Certainly, there are many things you can close a thyroid incision with. I like it primarily because I feel comfortable letting my patients shower the same day, and I think people like to take a shower after surgery. It also, generally speaking, keeps the wound clean, and it's pretty easy to manage. It does peel over time, which I think sometimes freaks people out a little bit, but generally speaking, it works well. It keeps it clean and it lets you shower. The one thing I do warn people about, if you're wearing a shirt or anything and it touches it, sometimes you'll get some of the fibers of the shirt, and then people think it looks dirty and they get worried that now my scar is dirty. And so I usually tell my patients, don't worry about that. It's just the surface of the dermal bond facing your skin. So I do like it. I do use it pretty frequently for my thyroid surgery. The only exception is really my patients that have that are known to develop keloids or hypertrophic scars, especially people with darker colored skin. I do use a buried proline suture in them, subcuticular, which I actually take out after 3 to 5 days. And I typically tape the ends. So I use steri strips for that and tape the ends in the steri strips so you can't accidentally pull it out. And so I find that works pretty well.
Excellent. Well, Daria, I think we've done everything we could to discuss how to minimize the scar, but I think your next question will be what we do for when the scar goes badly. Mhm.
Right, but before I jump into that,
sure.
if you have the silicone sheet, do you have to put sunscreen on top of the silicone?
No, you put the silicone sheet on usually for about 6 hours at nighttime, and then during the day you put the sunscreen on.
Okay. And then if you're using a heavy scarf and a silicone strip, do you also need sunscreen?
I would imagine if the scarf is covering the incision, you wouldn't need sunscreen. Yes, that would be fine.
So
And
I have to interject, at the last American Thyroid Association, there was a booth with a vendor that was selling kind of these pretty cool loose collars to wear on your neck right after thyroidectomy. I thought it was kind of great because it's not as heavy as a scarf and it was in pretty colors. And I thought, what a great idea. Why didn't I think of that? Because certainly you do want to protect that incision and keep the sun off of it while it's healing. And, do as much as you can to be gentle to that skin. But I thought, what a great idea. I can't remember the brand name of it, so I can't endorse it. But anyway.
I know I'm not a panelist, but I'll toss this in just as a survivor. There's a brand called Coolabar, which makes basically clothing and scarves and hats and all kinds of things that are equivalent to a 50 SPF. And I own lots of their stuff. It's really helpful. Okay, let's move on. So I've heard about keloid and hypertrophic scars. We've heard it already this evening. What's the difference? How often does this happen? And what can be done if my scar ends up like this? And while you doctors are helping us understand this, I'll advance the slide to this nifty picture, which helps kind of explain visually the two different types of scars.
Maybe we'll ask Hutan to take a shot at this. This is, every surgeon's greatest nightmare. And you could have the most flawless surgery, but end up with a scar that's just less than pleasing. What do you think, Hutan? What do you do to address these?
Yeah, so just based on the picture that we're seeing, keloid and hypertrophic scar, just briefly, a keloid is a scar that kind of grows outside of the original borders. And there's a genetic component to keloids. There's a lot more genetic component to keloids than anything. Hypertrophic scar is a scar that can just be sort of within the borders. It either widens, the scar widen, or the bumpiness is within the borders of the scar. And there is some genetic component to that as well. But as was mentioned before, a lot of times it also has to do with the tension around the scar. So we see a lot of hypertrophic scars in certain areas that's really hard to close without tension, like chest walls, backs. There's just always so much tension and so much movement there. So we talked about how to prevent them, but the question is how to address them. And I'll take the keloids first, because keloids can be difficult to address in general. Keloids are a response to a trauma to the skin. And so a lot of ways that we address them create more trauma to the skin. So there's a risk of creating more keloids. So initially, I take the keloid scars and I inject it with Kenalog, which is a type of steroid that can soften and flatten scars in general and keloids as well. It may work for a keloid scar, or it may not, and there's no rhyme or reason as to why. If it doesn't work, you can always do re-excision of the scar and close it. But if I ever do re-excision of a keloid scar and close it, then I'll do it in combination with radiation therapy, where you excise the scar, you close it with as little tension as possible, and you coordinate with radiation therapy, where they'll start getting low-dose radiation to the scar for 1 week every day. Now, in a setting of a cancer, I don't know what the ramifications of these are, truthfully. So I've been very cautious of that to recommend radiation therapy in setting of cancer, but it's low dose and it's low penetrating, so it shouldn't penetrate that deep. That tends to really, really decrease the likelihood of a recurrence after excision. It's actually amazing, the data that goes around that. Other techniques that's been used, there's been cryotherapy, where you freeze the keloid from the inside out to allow it to shrink. Serial excisions, where you excise them again from the inside out to make it smaller. People have used laser treatments for it with varying degree of success. But generally, if I have to re-excise it, I'll coordinate with radiation therapy to decrease the likelihood of it coming back. Hypertrophic scars, the best treatment for them after the initial steroid injections is, if someone's not happy with the way they look, is to cut it out and resuture it, and it works well. At least in my opinion, that's the best treatment at that point. These are mature scars, it's after months and months of healing that you get these scars. So it's not like the immediate scars that you get right away.
Okay. Mary, would you ever consider someone with a history of keloid to inject prophylactically at the end of a thyroid surgery?
Okay, so I'm a little scared to answer this because we have a facial plastic expert on the so forgive me and correct me if I'm wrong, but in somebody with a documented history of prior keloids in themselves, and there are parts of the body that are more prone to them, like joint incisions, chest wall, which I think was mentioned. The neck is thankfully very low risk for a keloid, but I will inject a little bit of Kenalog, which is a type of steroid, into the skin level after it's closed. And please, I'm open to criticism, but it seems to have worked really well for my patients who are at the highest risk. And then, as I mentioned earlier, I do everything I can to take the tension off that incision. I will close it with appropriate. Then also use a very tape that will, sorry about that for the feedback. I will use a tape that keeps the tension off, that stays on for about 10 days. And so please correct me, Hutan, if I'm committing sacrilege, but I do think that that's worked well for my patients.
Not at all. And there's plenty of data to actually say all of those things play a role in decreasing the formation of keloids. Injection of the steroids is something I do as well in patients who have keloids other places. I want to prevent it, and I'm just going to inject prophylactically. That's perfectly, that's the right thing to do, I think. I agree with you. The tension-free closure is the best technique we can do. And tape dressing afterwards is part of that tension-free closure, because during that immediate healing, you just put tape dressing to decrease the tension on the wound. So I agree with all of that.
Excellent. Daria, did you want to move on to question 4 for interest of time, or is that the plan?
No, I put it up there just because it's more of a, for the audience to go typing into the chat box if they want to share how they feel
Sure.
about it. are, because they're
Okay.
not going, we're not gonna, won't be able to use their microphones.
Okay.
There was a question about somebody having like another surgery because they have to do the completion thyroidectomy after having a partial in April. Is there anything different about managing that incision? Or is it going to basically heal the way they healed the first time?
That's an interesting one. Maybe I'll have Andrew look into it. Some people just cut into the incision and just close it. Some people excise it routinely. Some people just play it by ear. What do you do, Andrew? I know it's kind of a, it is kind of an ambiguous issue.
Yeah, I think it's case by case. Some of it depends on the timing of the revision surgery. Where are they in the healing process and how have they healed so far? So if I'm worried that things aren't healing the way that I'd like them to, regardless of where they are, I wouldn't hesitate to cut out the old scar. However, if they've healed really beautifully and it's a very fine line, then I would just go right to the scar and I wouldn't necessarily excise it. Oftentimes, if you're doing a completion, you don't necessarily need to use the entire old scar either, depending on how lateral that is or how far that extends. So sometimes you can get away with just a portion of the scar, or just extending it a little bit more to the side that you're taking out as well. So it really is to me, it's a case by case basis. How does the scar look? Is it healing the way I want it to? And how far out are we from surgery in terms of the amount of healing done?
Got it. Hudan, I have another question that patients often ask, like, let's assume you have someone very, very cosmetically sensitive. I don't know, the VIP of the VIP, the Hollywood star beyond all imagination. As you and I know, we see them every day, whatever, right? Now, if they wanted to truly maximize their scar and they see a dermatologist who recommends a couple other things that we haven't really talked about yet, dermabrasion or laser, would you ever recommend those prophylactic, like right after a thyroidectomy, no matter how it looks, no matter how beautiful or unbeautiful it looks, and what's the timing?
So it really depends on their skin type, of course.
Okay.
So the lighter skin types, prophylactically, I do treat the redness with IPL. So I'll do IPL treatment to the scar just to get the redness to go away faster. Now, that doesn't make the scar look any better in the long term. It's just going to improve that immediate redness that a scar can have for 3 months. Treating it with like an IPL, or some people have a pulse dye laser, treated with a pulse dye laser, it can just make the redness go away faster, because that redness is typically vascularity, and these lasers are absorbed by hemoglobin and cause the blood vessels to go away faster. Timing, I usually wait a month after the surgery to do the first session, and then you'll do 1 session a month for 3 months. Dermabrasion, some people will do dermabrasion, like when they're closing an incision, they'll use like the blade to kind of dermabrate the tissue around to close it. I don't know. Dermabrasion looks great if the scar doesn't look good after a while. I don't know if it's a good prophylactic treatment. There's a lot more inflammation around that time, and you'll just have a worse looking scar during the short time frame that it's healing. But if we're talking about a longer term scar, and let's say it's either a depressed scar or pigmentation is off, you certainly can do a resurfacing laser, like a CO2 resurfacing, although in the neck, you will probably have to go with a YAG or something that's less of an ablative than a CO2 resurfacing. You can do that to improve the texture and improve the pigment. You're limited in the skin colors that you can use that for. So, and we qualify by Fitzpatrick, like 1, 2, 3, 4, 5, and 6. So 1 and 2 are essentially Caucasian, 3 and 4 are Middle Eastern Asian, and 5 and 6 are African and Southeast Asian kind of skin colors. Probably up to skin 3, you could do resurfacing without worrying about causing pigmentary issues. Certain lasers you can use 4 and maybe 5, but skin colors type 6 is very difficult to treat with these kinds of interventions. But yeah, IPL, I do that in my 1, 2, and 3 Fitzpatrick's to treat the redness, to make the scar just look better faster.
Okay. And to be, just to be honest, what you're describing is for maybe the select few where it may not turn well. The vast majority of thyroidectomy patients will never need IPL or PDL or laser, in your opinion.
Absolutely.
Yeah.
Absolutely. Yeah, the vast majority, scars mature over time, but really after about 6 months, once the color has started to normalize, they become just far more imperceptible. And really, as long as it's flat, the coloring is what's important. And as long as it looks like the rest of the skin around the neck, it becomes imperceptible.
There is a pigment related question where somebody's noticing increased redness during the day compared to nighttime, and how do they improve the redness in the scar? This is somebody who had surgery 5 weeks ago.
If I may, so 5 weeks is pretty soon. It's okay to get some redness during the day as you're going. Again, that redness is vascularity. You're up and about, you're moving, your blood flow is increasing, blood pressure goes a little bit higher. If you're outside, it's warm, you're going to get a much more red scar. If it's something that really bothers you, this is a kind of something that can be treated with IPL or pulsed dye laser just to make the redness go away faster. It will go away in time. So that as the scar heals and matures, that extra vascularity goes away naturally. But if it's something that's bothersome, can be treated with those types of lasers at this stage to just make it go away faster.
And should there be any kind of a discharge around the scar after surgery?
Maybe Michael, you could take that. It sounds like it may be specific to that patient, but what do you think?
Yeah, you shouldn't have any discharge from around your incision after surgery. So if you do, that's probably something you should go get checked out, because that would imply potential things like an infection of the area, or sometimes you can get a collection of fluid under the skin called the seroma that will leak out through the incision. So I would say that would be abnormal. You should probably go talk to your surgeon and have them take a look at it.
And what about people who've had surgery a while ago? There's a question in here about, how could they improve their scar 2 years later? It seems like it's still changing. And some other people mentioned, like what could they do longer term?
I would say that's a tough one to answer, because after it's matured, it's somewhat mature unless you start over again. Would you agree, Hutan? I think there's really nothing you can do after the fact without starting over.
Yes, I agree with that. It depends on what's bothering them about it, right? If it's just sort of texture irregularity, you may be able to do dermabrasion, you may be able to excise and resuture it, like you said, you may be able to do lasers. If it's pigment abnormalities, that's a little bit more difficult at that stage to address. And again, like you said, you may have to just go back and cut it out and resuture it at that point.
Great, thanks. Other questions, Daria, from
Yeah, there's a few. People are concerned about like an uneven scar where like part of it is popped up a little bit and the rest is kind of flat.
This looks like, from this person, it looked like maybe it was shortly after surgery. If that's the case, then a lot of times that's the lymphedema, or the collection of fluid around the incision, which can come from when the surgeons are raising the skin up to get down to the thyroid. So that will go away. If that's the case, that goes away typically with some massage or over time.
And then what about larger scars, like with a lateral neck dissection, where it's just more scar length, I guess? Is there anything different that you do when dealing with a larger scar?
So larger scars heal at the same rate as the smaller scars, and typically we treat them pretty much identically. With a lateral neck dissection incision, typically it goes up a lot further, and it's not always as in line with the natural neck creases, and so sometimes that upper limb that goes up towards the ear can be more visible. But the truth of the matter is, it's treated the same way as, we treat them the same way as we do the thyroid incisions. Keep the sun off of it. The same concepts as the thyroidectomy incision really hold true.
And I'd add that some surgeons will do like a longer incision, but keep it within a crease rather than do the upper limb or the hockey stick, just so it falls within the natural skin lines. And sometimes that helps as well.
And somebody's asking if you could actually demonstrate the massage technique. We did that a little bit earlier in the session. So I would say, you know, when we put this out on YouTube, you can go back and watch that. Also, I believe that the chat is disabled, so apologies for that. About how long does it take for scars to heal? I think you have kind of covered that in saying after a few months, things tend to kind of go to their normal state. Anything you want to add to that question,
Yeah,
Doctor?
I mean, I would just say, maybe I'll ask Hutan really quick, because, you know, just not to confuse our patients, but, you know, Mary was saying that at 3 months, it starts to settle down and normalize. But then Hutan usually says he waits 1 month before he starts to take action. Hutan, what do you, I agree with Mary. I've seen that in general. What do you think?
So, I mean, within
when
3
should you
months.
call red alert? Yeah.
Oh, red alert. So, you know, the action that I take is for those patients that are like concerned, oh, it's red, and I want the redness to go away faster. So I just do that at that point. But I agree. So, you know, the scars tend to go through that initial maturation and contracture, all the phases within the first 3 months. And then for really up until 1 year, there is some remodeling that ends up happening underneath the skin to the scar. So that fully healed scars are generally that 1 year apart. But after 3 months, they pretty much look really good and normal. So the interventions that I take are generally for patients that are just more concerned. They want it to look better faster. And I'm really mostly addressing that redness in those patients because that can be, you know, very visible. So if you can address the redness faster, then that's what I do. And but otherwise, I completely agree. After about 3 months, the scar has gone through its maturation, all the phases of healing we hear about, and then for the next year or so, it just undergoes this sort of a remodeling underneath, where the collagen deposition just changes patterns and becomes even more mature. So so I agree. After 3 months, it should be fine.
Well, I gotta say, Jerry, this is one of those topics that there's so much to discuss, but so little time.
I know there's two questions that I think we can smush in, and then we're going to have but are all silicone sheets and treatments created equally, or is there a medical grade that would be better? That's one question. And another one is, do you put the silicone gel and then a silicone sheet on top of it, like layering, or do you use them separate? So two kind of silicone related questions, and then we're going to have to wrap it up.
Maybe we'll let Mary speak in on those points.
So I thank you, because I do want to interject on that. Basically, I say that the best silicone to use is the one that's easiest for you to find. So I do recommend to the patients, if they go in the wound care aisle in their local CVS or Walgreens or local drugstore, that one of the common brands is Scar Away, and Scar Away has both gel and sheets. But really, the most important silicone is the one you can get easiest in your local drugstore.
Awesome. Okay, I can't believe how quickly that this hour has gone by. This scars is always an exciting topic and something we can all relate to. So first of all, thank you to our panelists. It's always a joy to have doctors like yourselves that are willing to take time out of your valuable lives and answer our questions and talk directly to patients. That we appreciate it so much. A reminder to everybody that we do have another couple of sessions that we will be co-hosting together with ThyCa and American Head and Neck Society. So mark your calendars for Thursday, September 14th and Thursday, December 14th. A little reminder, September is Thyroid Cancer Awareness Month. And then we have to put in a plug for our conference. The ThyCa conference is coming up. Please mark your calendars, October 13th, 14th, and 15th. We will be in person again, hooray, in Denver, Colorado. But we've also been virtual for the past several years. So this will be a hybrid conference and we will have a virtual option. So hope to see you all at conference, either in person or in the virtual space. And thank you, everybody.
Yep. On behalf of American Headache Society, we really want to say we appreciate all the time that our panelists have given, as well as the patients that contributed. We learn from patients just as much as patients learn from physicians. So this is truly an honor to continue these webinars, and we hope we can continue the momentum.
Awesome, awesome. Thanks, everybody. Have a nice rest of your evening, and we'll see you in September at the next one.
Thank you.
Thank you all.
Thank you.